Acquired cataract. First one, age-related cataract. The first type is subcapsular cataract, which you can see in the picture A and B. Anterior subcapsular cataract lies directly under the lens capsule, associated with fibrous metaplasia of the lens epithelium. Posterior subcapsular opacity lies just in front of the posterior capsule, has a granular plaque-like appearance on oblique slit lamp microscopy. Here you can see, but typically appears black vacuolated on retroillumination in picture B. The vacuoles are swollen, migratory lens epithelial cells, also known as bladder or Weddell, similar to those commonly seen postoperatively in posterior capsular opacification. Due to its location at the nodal point of the eye, posterior subcapsular opacity often has a particularly profound effect on vision. Patients are characteristically troubled by glare, for instance from the headlights of oncoming cars, and symptoms are increased by miosis, such as occurs during near visual acuity and in bright sunlight. Another type is nuclear sclerotic cataract, as shown in picture C. Nuclear cataract is an exaggeration of normal aging change. It is often associated with myopia due to increase in the refractive index of the nucleus, resulting in some elderly patients being able to read without spectacles again, also known as second sight of the age. In contrast, in the healthy aging eye, in occasional cases of cortical and subcapsular cataract, there is mild hypermetropic shift. Nuclear sclerotic cataract is characterized by a yellowish hue due to the deposition of urochrome pigment and is best assessed with an oblique slit lamp beam. Retroillumination will show a good red reflex, but careful observation will reveal a subtle distinction between the nucleus and cortex, as shown in picture D. When advanced, the nucleus appears brown and in rare cases black. Another type is cortical cataract, as shown in picture E and F. It may involve the anterior, posterior or equatorial cortex. The opacity starts as clefts and vacuoles between lens fibers due to cortical hydration. Subsequent opacification results in typical cuneiform or wedge shape or radial spoke-like opacities, as shown in picture E and F, often found initially in the inferonasal quadrant. As with posterior subcapsular opacity, glare is a common symptom. Another type is Christmas tree cataract. Christmas tree cataract is shown in picture G and H. It is uncommon, characterized by a polychromatic needle-like formation in the deep cortex and nucleus. Cataract maturity. Immature cataract is one in which the lens is partially opaque. Mature cataract is one in which the lens is completely opaque, as shown in picture A and B. Hypermature cataract is shown in picture C. It has a shrunken and wrinkled anterior capsule due to leakage of water out of the lens. Morganian cataract, as shown in picture D, is hypermature cataract in which liquefaction of the cortex has allowed the nucleus to sink inferiorly. Cataract in systemic disease. Number 1. Diabetic mellitus. As shown in picture A, hyperglycemia is reflected in a high level of glucose in the aqueous humor which diffuses into the lens. Here glucose is metabolized into sorbitol which accumulates within the lens, resulting in secondary osmotic overhydration. In mild degree, this may affect the refractive index of the lens with consequent fluctuation of the refraction in line with the plasma glucose level, hyperglycemia resulting in myopia, and vice versa. Cortical fluid vacuoles develop and later evolve into frank opacities. Classic diabetic cataract, which is rare, consists of snowflake cortical opacities as shown in picture A, occurring in the young. It may mature within a few days or resolve spontaneously. Age-related cataract occurs earlier in diabetes mellitus. Nuclear opacities are common and tend to progress more rapidly than age-related nuclear sclerosis. And there is myotonic dystrophy. Here you can see in picture B, about 90% of patients with myotonic dystrophy develop fine iridescent cortical opacities in the third decade, sometimes resembling Christmas tree cataract. These evolve into visually disabling wedge-shaped cataract, cortical and subcapsular opacities, often star-like in conformation, as shown in this picture. By the fifth decade, later the opacities may become indistinguishable from the typical cortical cataract. In the picture C, you can see cataract caused by atopic dermatitis. About 10% of patients with severe atopic dermatitis develop cataract in the second to fourth decade. These are often bilateral and may mature quickly. So these are bilateral and may mature quickly. Shield-like dense anterior subcapsular plaque that wrinkles the anterior capsule is characteristic. Posterior subcapsular opacities may also occur. Another disease is neurofibromatosis type 2 is associated with early cataract in more than 60% of patients. Opacities are posterior subcapsular or capsular, cortical, mixed, and tend to develop in early adulthood. Next topic is secondary cataract or complicated cataract. It develops as a result of other primary ocular disease. For example, as shown in picture A, cataract caused by chronic anterior uveitis. It is the most common cause of secondary cataract, the incidence being related to the duration and intensity of inflammation. Topical and systemic steroids used in the treatment are also causative. The earliest finding is often a polychromatic luster at the posterior pole of the lens. If inflammation persists, posterior and anterior opacities develop. Cataract appears to progress more rapidly in the presence of posterior synecdoche as shown in picture B. In picture C, cataract caused by acute congestive angle closure. It may cause small anterior gray-white subcapsular or capsular opacities. Glaucom flecken, in picture C you can see, to form within the pupillary area. These represent focal infarcts of the lens epithelium and are pathognomonic of previous acute congestive angle closure. High myopia can also cause cataract. Pathological myopia, it is associated with posterior subcapsular lens opacity, early onset nuclear sclerosis, which ironically may increase the myopic refractive error. Hereditary fundus dystrophies is shown in picture D. Hereditary fundus dystrophies such as retinitis pigmentosa, Leber congenital amaurosis, Garrett atrophy, Stickler syndrome are usually associated with posterior subcapsular lens opacity. Anterior subcapsular lens opacity is rare, as shown in picture D. Because surgery is usually undertaken at an early stage, when the opacification is limited to the posterior subcapsular region, cataract surgery tends to improve vision function even in the presence of severe retinal changes. Cataract can also be formed secondary to medication such as systemic and topical steroids can lead to cataract formation. These are usually posterior subcapsular in appearance and can be visually debilitating. Despite a good visual acuity, symptoms of glare and reduced near vision are pronounced. Long-term use of chlorpromazine leads to anterior star-shaped lens opacity. Traumatic cataract. Trauma is the most common cause of unilateral cataract in young individuals. Penetrating trauma is shown in picture A and B. Blunt trauma is shown in picture C. Blunt trauma causes characteristic flower-shaped opacity. Electric shock, as shown in picture D, is a rare cause of cataract. Patterns include diffuse milky white opacification, multiple snowflake-like opacities, sometimes in stellate subcapsular distribution.